We know from the literature about the RET translocations that approximately 1% of patients with adenocarcinomas have RET translocation in the tumor.
RET aberrations consist of so-called translocations. In case of a translocation, the gene is broken apart and part of the gene fuses with another gene, and that leads to activation and physiological activation of this, in that case, RET oncogene. It's a typical type, same type of aberration as we know from ALK rearrangement and ROS1 rearrangement, same principle. RET testing is not very frequently asked for at this time because there is no approved treatment available. However, in selected cases, the oncologist asks us for RET testing. And the only valid method at this time, I think, is FISH analysis with a break-apart FISH probe, as we use it for ALK testing and ROS1 testing, just without the components of the FISH probe.
The first reports on RET fusion in lung cancer were in 2011 and mainly 2012, and that this can be a driving mutation which can be targeted. So we wanted to know whether we can find these translocations in our clinical samples in the daily routine. And we organized to implement the RET FISH testing in the routine and to look how many cases are positive. So within the first 12 months we had analyzed 529 clinical samples in a diagnostic routine manner, and we had 12 positive samples which correspond to 2% incidence, which was a little higher than the literature because we have some patients who were already tested negative for other markers, so we had an enrichment of the pan-negative population, and overall it seems that the incidence of RET fusion in lung cancer is still about 1%. We can say from the literature and the conference reports, especially from the US group, that there is evidence for activity for cabozantinib. Also there may be evidence for vandetanib. There is also ponatinib, a potent RET inhibitor. But as we said earlier, these are not registered or approved for lung cancer. So we really hope to have further clinical trials very soon, also in Europe. And then I think it really makes sense to have a broad testing of the patient for inclusion in those trials. And this will be a challenge because we have to refer patients to active centers.
Nowadays, testing for RET rearrangement in patients should be made on an individual basis in special patients. That could be young patients who have recurrence or have advanced metastatic disease. So it's really on an individual basis, because testing is a bit problematic if you think about that you need to test like 100 or 200 patients in order to find one rearrangement. So that's rather tricky. At this moment, I think, as you said in your cohort, selection of patients by previous results, like use only patients who had already ALK, EGFR, KRAS testing, and exclude all those that had a positive result with these mutations, and you will increase the prevalence of RET rearrangement in the remaining cohort. The RET testing would be much easier and straightforward if we had an immunohistochemical test assay available, which is not yet the case, because that could easily be applied to almost every patient. In the short or long run, I think next generation sequencing technology will be the solution, because one can foresee that within a short time, let's say within a year, every patient will have a comprehensive testing of a panel of approximately 50 genes, and that might hopefully also include rearrangement. Rearrangement testing by next-gen sequencing technology is not so easy as mutation testing, but there is a lot of effort being invested to get this running.